Thank you for joining us. The webinar will begin shortly. Good morning, everyone. Welcome to today's episode of PYA's Healthcare Regulatory Roundup Compliance Webinar Series. Today's topic is providing and billing Medicare for care management and remote monitoring services. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the Q&A pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any additional comments or questions. Any questions posed during the webinar will be responded to via email after the webinar. We've posted a PDF copy of the presentation slides for your reference in the resources pane. Also, you will receive an email later today with a copy of the slides and a recording of the webinar. You can customize your viewing experience by resizing, moving, or minimizing all of the panes within the webinar.net platform. With that, I would like to introduce our presenters, Martie Ross and Lori Foley.
Thank you, Jennifer. Good morning, everyone. Thank you for joining us. I am Martie Ross, principal in PYA's regulatory compliance team. I am joined today by our fearless leader on that team, Lori Foley. And our topic today is Medicare reimbursement for care management and remote monitoring services. And this is a webinar that has been a decade in the making, with CMS first introducing reimbursement for chronic care management now 10 years ago in 2015. Actually, the story goes back further to 2010 with the passage of the Affordable Care Act, which put CMS on the long and tortuous path, transitioning from fee-for-service to value-based reimbursement models. The idea behind the reimbursement for care management and remote monitoring is to help providers build that critical infrastructure to support participation in those value-based models. But certainly it has been a challenge for providers to understand these rules and implement these rules and maintain compliance with these rules. And so Lori and I have been in the trenches along this 10-year path, tracking, I know, 10 years.
10 years.
10 years. But we've really tracked very closely, the publication of the rules in the Federal Register, as well as any of the supplemental guidance that CMS has offered in FAQs, webinars, and the like, and try to provide this to you in as a comprehensive and as direct and forward manner as possible. So today, in the next 57 minutes, we will cover the rules for the care management components, so the traditional chronic care management, complex chronic care management, and principal care management. We're going to introduce the newbie on the block, which is advanced primary care management, which CMS has now been reimbursing for 41 days or so. We'll then delve into remote patient monitoring, both physiologic and therapeutic monitoring. We'll wrap up with a discussion of the change in the rules regarding how rural health clinics and federally qualified health centers provide and are being reimbursed by Medicare. And finally, very briefly, touch on how other payers have been addressing these services and reimbursing for them. So let's get started with CCM, complex CCM, and PCM. And we apologize in advance to the uninitiated for our excessive use of acronyms in the discussion of these rules. But chronic care management every single time is a mouthful, so we'll say CCM. As is principal care management, that's our friend PCM. We'll start with the codes, just to familiarize ourselves with the expectation. The granddaddy of them all is CPT 99490, which is reimbursement for chronic care management, 20 minutes of service furnished by clinical staff under the general supervision of the billing practitioner. The requirement for an individual to receive these services is they have at least 2 chronic conditions that are expected to last at least 12 months or until the individual's death. And that the core of this is working from a comprehensive care plan developed by the care team. The add-on code is 99439, which is what you bill for each additional 20 minutes of service that you provide. CMS has put an upper limit as part of their correct coding initiative. They have imposed a limit of 2 units of 99490 as reimbursable. So you will receive payment for up to providing 60 minutes of CCM services. Beyond that, there's no reimbursement for additional time, or if we find another code to bill that additional time under appropriately. We then introduced CCM not furnished by clinical staff, but directly furnished by a physician or non-physician practitioner. That is billed under 99491 with the add-on code of 99437. Important to note that this code is in 30-minute increments, not 20-minute increments. And so you get reimbursement up to an hour and a half of these services. Again, even though these are provided by the physician or non-physician practitioner, you have to fully cross the minimum minute requirement to qualify under this code. CMS subsequently introduced an animal called complex CCM, billed under 99487 and 99489, that being the add-on code. This is a 60-minute code and a 30-minute add-on code. Again, this is the model of services furnished by clinical staff under the general supervision of the billing practitioner. What we add here with complex CCM is the severity of the patient's condition, so that it requires a moderate to high complexity medical decision making. So that's our new element in complex CCM. There is no CPT code and no separate Medicare reimbursement when complex CCM is performed by the physician or non-physician practitioner. And note, at the end of the day, 2 units of 99490 plus 2 units of 99439, which means 60 minutes, the equivalent of 99487, actually reimburses higher. So doing just CCM reimburses higher. The reason you get into complex CCM is when you'd expect to go to 90 minutes, and then the reimbursement would be higher under the complex CCM model. CMS subsequently introduced principal care management. This is the service to be provided when you are focusing on one particular condition with a patient. So this is referred to often as specialist-based care management services. So if we're managing a patient's cancer diagnosis, for example, and providing that ongoing care management service focused on the treatment for that particular condition, then that's when we would use the principal care management codes. This is also measured in 30-minute increments with the add-on code on 99427. Interestingly, CMS allows 3 additional units of this code. So this one actually gets you to an hour, 2 hours of providing services. Is that right? Yeah, 2 hours of providing the services. Note here, there's some additional requirements with regard to care coordination that are specifically called out with principal care management. We then have the set of codes for, there we go. We have the set of codes for delivery of principal care management by a physician or a non-physician practitioner. And again, unlike CCM, where the time increases from 20 minutes to 30 minutes, remember that principal care management is going to stay at 30 minutes across the board. So that gets us to questions regarding utilization of these codes. Since CMS created this reimbursement and has continued to develop it over the last 10 years, are we seeing significant uptake by practitioners? And what you have here is the utilization in traditional Medicare for 2022. That's the most recent data that CMS has made available. Obviously, 99490 is the dominant code. You're seeing about 100,000 practitioners have delivered this service, unique practitioners, and they've furnished the service. I said that backwards. My apologies. You have about 29,000, practitioners providing the service to about 100,000 unique Medicare beneficiaries. And on average, a beneficiary is receiving 5 services over the course of a year of the service. It sounds like big numbers until you consider what is that in terms of the percentage of Medicare population generally. There are now about 30 million traditional Medicare beneficiaries. Well, that was in 2021 for comparative sake. And we estimate that about 2/3 have 2 or more chronic conditions, meaning that about only 5% of those potentially eligible for these services are receiving CCM services today. And out of the million physicians enrolled in Medicare, of which about 360,000 are going to be your traditional PCPs, you're only seeing about 10% of those physicians that are furnishing these services today. So certainly still a long way to go in terms of adoption of these codes. There are a number of obstacles, including compliance with the specific billing rules, questions regarding the adequacy of reimbursement. All of that's on the table. So here I'm going to turn this over to Lori to delve into some of those, all of those very complex billing rules across the CCM, complex CCM, and PCM world.
Perfect. Thanks, Martie. It has been interesting. I know we fully anticipated a bigger uptake of particularly CCM when it first rolled out, because we felt like so many providers were providing a good portion of, the outside the visit types of care. We thought it would be adopted, but I think a lot of the different criteria that we'll talk through impeded some of the adoption for providers. But I would say over the years, Medicare continues to try to address through FAQ and MedLearn Matters and tools to make it easier. And hopefully today's conversation will help as well. So we're going to spend just a little bit of time going through these components of the billing rules. They're very similar from model to model, so CCM, complex CCM, and PCM as we go through. Definitely starts with consent. Sorry, I'm learning the new format. Here we go. Starts with consent for the patient. And Medicare feels very, very strongly that providers must explain the service to the patient and obtain and secure consent. And in addition to explaining that the nuances of the program and what the services will be, it is also informing the beneficiary that only one provider can provide these services at a time. The beneficiary may stop them at any point in time, that and that they are responsible for any copayment or deductible. Now, if they have a secondary insurance, we do see most of the secondaries pick that up. So not every patient would have an out-of-pocket, but you do have to inform them of that responsibility. That consent can be obtained written or verbally. And if it is verbal in particular, then it needs to be documented in the medical record, both that the patient was consented, that the program was explained, but also that they affirmed their understanding of those additional elements, specifically that they have that cost sharing, probably most importantly, that they have that cost sharing element. So when we're auditing, we're looking for that in the documentation of a verbal consent. If the patient chooses to revoke their consent, which could be inferred by signing up with another provider, then the practice can only bill for this current month, assuming they hit the other requirements of the code, and then no billing after that particular month. So, and CMS didn't give specific guidance if they have to give it, can they give it verbally? Do they have to give it in writing? It just says if the patient revokes consent. So you would want to document that if it were revoked.
Lori, one common question we get is who can give consent? And though CMS has not directly addressed it, our advice typically is follow your state rules regarding consent to treatment.
Right, absolutely. And documenting that too, if it is an individual other than the patient. So it is, if a provider has not seen a patient within the last 12 months, then an initiating visit is required with a new patient or those patients not seen within that time frame. That initiating visit can be a comprehensive E&M visit, so levels 2 through 5. It could be a transitional care management, post-hospitalization, an AWV, annual wellness visit, or the Welcome to Medicare IPP exam. It has to include, if you're having to do that, the initiating visit, that discussion must verbally include the discussion on chronic care management. The conversation or the interaction itself is separately reimbursable. You can use GO 506 as an add-on code for assessment and care planning. The preparation of the care plan is not included in that E&M visit. And it can be performed via telehealth only if it's a reimbursable service. That service is already allowed to be telehealth performed. We have a lot of conversation regarding the billing practitioner versus the referring practitioner. So CCM is billed under the NPI of the practitioner who's providing that general supervision of the staff. So recall that Martie, when she was going through the codes, some of the codes can be performed by under general supervision by clinical staff versus personally performed by the provider. If you're doing the general supervision, then that practitioner could be different than the ordering practitioner. For example, we have groups where the practice is launching a CCM program. One physician's taking responsibility for supervision of the care teams. Those services would then all be billed under that supervising physician. It does explicitly allow for the use of case management companies. Again, making sure that those general supervision arrangements are in place so the care team has access to that physician or practitioner. And then you can use those shared and centralized services like I described in that practice. There are certain required capabilities that the practice must have related to billing for CCM, specifically the use of a certified EHR for specific purposes. CMS acknowledged that a lot of particularly at the time that these codes rolled out, a lot of the electronic health records did not have good care planning tools. So most practitioners used an external care planning tool. And so the requirement was that you have certain capabilities within the EMR itself, such as recording patient demographic information, keeping an updated problem list, having medications and allergies recorded in the record, and a structured summary of the care. But then you could use additional tools for the care plan itself, for example. The beneficiary has to have access to care, meaning they're seeing successive routine appointments with the same members of the care team. So it's not that they're just catching the next available provider and there's no continuity in the care being provided to the patient. And then additional access for 24/7 ability to reach out to the care team, regardless of the time of day or night for acute and urgent needs. The care team is responsible for following up for transitions of care. So after an ER visit, after hospitalization, sometimes that would be in a situation where where you would evaluate if you were providing transitional care management. We'll talk about codes that can and can't be billed together. If sometimes it's an economic decision, sometimes it's making sure you hit all the different criteria for those codes. But either way, making sure that patients' coordinated care as they're moving through different areas of the health system is important, including coordinating referrals and making sure that sharing information electronically with other clinicians in the care team. And that leads into that last bullet, that coordination of care, particularly with chronic care management. CCM, the care plan is intended to design and address all of the patients. So that's including coordinating with home and community-based service providers to meet psychosocial needs and any functional deficits that the patient may have. So let's talk a little bit more about general supervision. That one gets folks tripped up a little bit. And so CPT defines the person who works under the supervision of the physician or the non-physician practitioner and who is allowed by law, regulation, and facility policy to perform and assist in the performance of those services, but is not the individual who would report that service. So the billing practitioner is responsible for providing that general supervision to the clinical staff. And that includes oversight and direction of the care management program itself, ensuring that the staff has the expertise and the training necessary to perform the services that are being rendered, so that delegation of authority, the ability to be available to address any staff questions or concerns, any care issues that get elevated. They don't have to be physically or virtually present when the staff is providing those services, or to review and sign off on documentation one by one, but they do need to be actively engaged in the program, in the staff supervision, the training of the staff, and then interacting with the patient in the care plan or through the care plan. And we'll talk about that a little bit more when we talk about audit risk.
You know, Lori, we've talked to folks about this general supervision, trying to draw an analogy to the state licensure, and that a physician can delegate specific tasks as he or she believes appropriate. It's that the individual to whom that activity is then delegated, it's still the physician's license on the line. And so that's sort of the analogy here, is that yes, you can delegate these care management responsibilities, but appreciate billing practitioner. It's always going to come back on your license, whatever they do. And so that's the appropriate level of supervision of that staff.
And I think that's where, particularly when clients are using an external party to provide that care management team, you have an ordering physician who may be different than the supervising physician. And a lot of times the care team has somebody on site, a physician or a nurse practitioner that they're maybe elevating questions to, but really it's the connection from the care team to the physician in the practice, the clinician that's billing for the services and overseeing really the patient's day-to-day care.
Yeah.
Good points. The care plan has to be developed and regularly updated in an electronic format. So again, if your EMR has it, that's great. We're seeing more EMRs have more tools related to care plan management, but if not, then using an external electronic care plan is also acceptable. And again, the care plan has to be fully functioning under CCM to base on the whole of the patient. So to qualify, the patient has to have the 2 or more chronic conditions, but the care plan isn't just focused on those conditions. It's the entirety of the patient. So physical, mental, cognitive, psychosocial, you see all the lists here. It needs to include an inventory of the resources and supports available to the patient that they're taking and utilizing and or could avail themselves of in order to address certain circumstances. Mentioned all of the health issues. For principal care management, that one is more limited to focusing on the diseases at hand. So we do see providers, sometimes that's where we see more specialists using principal care management, oncology, cardiology, for example. They're really treating a more narrow focus of the disease state. And so the care plans are able to be more narrow to reflect that in particular. It's important that the care plan is aligned with the patient's, the beneficiary's choices and their values. And again, clinical staff at the delegation of the practitioner can create the care plan. The billing practitioner then would review and sign off on it. As far as accessibility, the practice must, or the provider must make a copy available to the patient, and that could be paper or electronic, depending on the patient's preferences, and then be able to share that care plan with others on the care team.
Yeah, CMS has been pretty quiet in its guidance on CCM and its related services since the pandemic. But one clarification they made this year that I thought was really interesting was with regard to the authorship of the care plan, noting that clinical staff can develop the care plan and then can be submitted to the billing practitioner for review. So just something
that operationally most inferred that, but it was nice to have it tied in a bow.
I love it when it's actually on paper.
Tied in a bow. No gray area right there. So for the care management services themselves, a lot of times they're not face-to-face with the patient. So it is looking at the performing medication reconciliation, making sure that they're self-medicating, that they're taking the drugs the way that they're supposed to get the outcomes to control those chronic conditions, making sure that they're getting their preventative services, that they're getting addressing their overall condition, including their physical, mental, and social condition, and then addressing social determinants of health, the SDOH. And including in that the documentation, CMS was a little light on the documentation. I think it's one of those where you know it when you see it. At a minimum, it should include the date and the time of the interactions. We recommend start and stop if it's feasible, but sometimes it's not. But having a good accounting of the date, the time, the person performing the services with the authentication of that individual. So if it's a medical assistant, an LPN, that gets noted, and then a brief description of the services. It doesn't have to be a diary of the whole day or the whole interaction, but looked at this, interacted that, responded to the patient, communicated with the physician. Those are all examples of good documentation. We did reference the requirement that the services be performed if you're using Incident 2, that you are using the clinical staff. So for example, the receptionist's interaction with the patient to coordinate to the care team doesn't count for these care management services.
I've heard more. I'd love your view on this, Lori. This question's come up more and more about these assumed time rules, especially with care management companies. They'll say, if we do X, we assume it took X number of minutes, and that's how we record the time. What are your thoughts on that one?
It is an interesting conversation. It's one where I have worked with clients that have done time studies and then record that. So over a period of time, here's how long it took. So then they got a little more comfortable with, some predetermined times to do these particular things. And then they updated those time studies on a regular basis. I felt like that's a reasonable paper trail, but I think it comes down to risk tolerance. We are always happier when we see real time and knowing that every phone call is not 5 minutes. We know that sometimes it's 8 and sometimes it's 2. So good tools help with that as you're counting those minutes. They could include face-to-face services as long as it's not, associated with another visit. So for example, you couldn't count time associated with an E&M visit towards care management services. So we would usually see those face-to-face as the exception, not the rule. Again, you don't necessarily have to interact with the patient. You could be interacting with the patient's family or caregivers or other providers, referral sources on behalf of the patients. Those minutes would count. If 2 people are talking together, if Martie and I were having a conversation about a patient, we both couldn't count our time. Only one of us could do that. You would not, again, include time that's part of another CCM or PCM service. You can aggregate minutes across multiple days, but you can't round up. So if you get to 19 minutes, you can't just fabricate, roll up to that 20. So you need a solid documented 20 minutes. Same for those add-on codes that Martie discussed earlier. You need it to be specific and documented in that area. And you can't carry time over from month to month. And then if, at first, Martie, I don't think we had clarification when it first came out. If you were doing something that inured the benefit of 4 or 5 patients, how you counted that, but we did get later clarification that if you're doing something that benefits more than one patient, you divide the minutes by those number of patients, and then that's how many you could count. So if you're doing 5 minutes for 20 patients, you couldn't give 5 patients, you couldn't add it on to every single one.
Right. And just note, every single one of these bullets ties back to an actual statement by CMS. So these are, in fact, points they look for in terms of auditing.
Yep. Double dipping, again, we mentioned at the onset, only one practitioner can bill for CCM for the same patient during the same month. And you cannot bill for chronic care management and principal care management. One practitioner can't bill for both of those for the same patient during the same month. One practitioner can bill for CCM and another can bill for PCM as long as they're different, addressing different states and different issues, even if those practitioners are part of the same group practice. You can't bill CCM and PCM during the same 30-day period as home health care supervision, hospice supervision, and ESRD services. And you can't count time spent assisting if the patient is inpatient in a hospital, part of a Part A SNF stay, or if they're also receiving transitional care management services. I think the only caveat that we've identified to that last bullet is if a patient discharges in the end of, you're providing transitional care management, the end of their 30-day period for the TCM is, say, mid-month. And then between that and the end of the month, you spend an additional 20 minutes that is not overlapping chronologically. Then you could potentially bill that 99490, but you would want to make sure everything lined up correctly.
Note that list of excluded services used to be, 3 times as long? It just CMS slowly whittled it down. So be sure you're staying on the most current advice. And
I think they were doing that trying to encourage adoption. I think that was one of the reasons that it became too tedious to keep up with. So we talked earlier about you would submit the claim under the NPI of the practitioner who's providing that general supervision. The place of service would be where the face-to-face visit normally would have occurred. And then the date of service could be any date within the calendar month after the minimum time threshold is satisfied. And so, and remember, if you're doing those add-on codes, they've got to be attached to the primary CPT code. So you would, most people wait towards the end of the month to make sure they have all of the minutes to do the math and figure out which units and which codes to bill at that time. And CMS continues explicitly over and over with all of these care management discussions to say they do not have the authority to waive copayment for care management services. That is beyond their purview and control. So they continue to put in those protections that we talked about with the consent, making sure that that's documented. But for now, that continues to be a factor where patients are responsible for that copayment.
Guess we just need another pandemic to wave the
You know,
yeah,
we had
no.
some key changes, but let's not. But, you know, talking about the pandemic, that's a good segue, Martie, into this. We are starting to see more enforcement of CCM in particular. If you think about, we talked about it started in 15, it really kind of got some traction, 16, 17. We were starting to see some inquiries and audits of chronic care management services, and then we did have the pandemic. So that put a stop to it. They changed, there were a number of flexibilities during the pandemic related to that. We've seen obviously that transition. So we are beginning to see more inquiries into CCM. This in particular, this case, for example, is resolving claims that they were using staff that were outside of the US and who were not qualified to perform tests. This was related specific to cardiac monitoring. We do see, we've had inquiries or seen challenges related to documentation of the care plan not being customized to specific patients, allegations of roster billing, because it is easy for folks to come in and say, you've got, this many patients that have more than 2 chronic conditions, let's roll them in. And then it didn't show the one-on-one patient care as they were going through. So we expect to see this continue to increase now post-pandemic and probably start to get some of the other care management, the principal care management in particular, now that it's been out a little bit longer. So a couple of things just to look out for that we see from a billing compliance perspective. So patient initiation is really making sure, again, that you've seen that the billing practitioner, the practitioner has seen the patient within the last 12 months, or that there's the discussion of CCM and that is documented in the record. The other thing is making sure that if you are audited and the records are requested, that you're including that consent documentation, which could be months in advance of the date of service that they have requested records for. So if you're preparing your team, you just need a checklist that says, here are all the elements. We need to make sure we send that patient consent, the patient initiating visit, the supporting documentation, understanding it could be, you know, you're looking at multiple dates of service to pull that full record together. That also referenced then just the patient consent. We do see where there might be a general note that says consent was obtained. And Medicare is very specific. It needs to say consent was obtained and patient understands the financial responsibility and only one provider can provide the services and that they can stop at any time. We do have some folks that use a script, and so they supply that script, and the note would say we use the script and the patient understands some sort of documentation that all of those elements are covered. And then we were talking about the documentation on time. Martie's question was a good one as far as individuals that may put buckets of time in descriptions, but we've seen descriptions where it's 20 minutes of care management services, and we've seen other descriptions where reached out to Mrs. Jones, blood sugars going up, recommended she call her physician, talk to the doctor, he wants to see her this afternoon. The latter is good description to really show that the team is interacting with the patient and providing that hands-on care management. And I think that's where we're seeing some of the challenges, is that there's just very, very vague as to who's doing what they're doing in that time for the government in particular to challenge it. Again, the care plan needs to be robust. It's got to be patient-centered. For CCM in particular, it's got to cover a lot of the different dynamics, all the different, the whole of the patient. We talked about making sure that the staff are eligible to bill. It has to be eligible practitioners, eligible staff. That varies depending on those CPT codes, not inflating that time, and then that supervision. We just can't stress that part enough, making sure that it's that person who's supervising the care and that's documented so that you can go back and say, here's how we structured our program. Here's the team that was providing the day-to-day services, and here's the provider that was doing it and how they intersected between those two. Woo, that's a lot on chronic care management there, Martie.
Well, let's talk about the new kid on the block then, Advanced Primary Care Management, or new acronym APCM. Again, we're now a month and a couple of weeks into billing for this. I got to give CMS some kudos, though, because they've actually issued some nice guidance being pretty direct in explaining this. There is actually a web page CMS has stood up which specifically addresses advanced primary care management. And a lot of the content we're going to talk about comes from there directly. So this is an attempt to take a value-based model and put it in a fee-for-service world. Because as you are well aware, CMS, through primarily the Center for Medicare and Medicaid Innovation, has rolled out a number of primary care-based alternative payment models. And those typically involve a capitated payment to the primary care practice based on the number of Medicare beneficiaries for whom that practice provides services. And that is typically determined by attribution. So who provides the most primary care services to this beneficiary, they're going to be attributed to that particular practitioner. So how do you take that model, the good stuff from those alternative payment models, and bring it to a fee-for-service world where you can't do attribution? And the answer to that is CMS's model for APCM, which they first rolled out in the proposed rule last year. So this is a vehicle for providing fee-for-service reimbursement to support a practice's infrastructure to do that team-based, patient-centered care. And they accomplish that with 3 new codes that you would bill on a monthly basis. They are based on the level of patient complexity, not the level of service provided. Where did that come from in the fee-for-service world? So it is a very novel approach CMS is taking here. There are the 3 codes, the 3 G codes. The first is for patients that have no chronic conditions, so sort of your run-of-the-mill Medicare beneficiary. Those that have multiple chronic conditions. And then a third category are beneficiaries that have multiple chronic conditions and are qualified Medicare beneficiaries. Who are these folks? These are your dual eligibles. These are the ones for whom you can never bill them personally for their copay or deductible, that in fact you have to bill the Medicaid program instead for that collection. For these codes, there are no minimum monthly requirements. Of course she decides to bark right now. I apologize for that. But this is the uniqueness, is there's like no particular service thing you have to do in a given month to bill for the code. And again, there's those services that would be provided for a beneficiary are going to be done primarily by, again, clinical staff under the general supervision of a physician who is the billing practitioner for the service. You see here the elements, both the service elements and the practice level capabilities that are required to bill APCM. They look a whole lot like the requirements that Lori just went through for CCM. But we've noted here the APCM elements that are beyond those basic requirements for CCM and PCM, including that very specific directive on enhanced communication opportunities, such as secured messaging, a patient portal, or virtual services. One of the requirements to provide this service is you have to have the capability to do that. You know, patient sends you a photograph of a rash, and you are able to look at the rash and make a determination, generally through some sort of patient portal communication. There are also these ongoing practice activities that are required, including the analysis of a patient population data to identify gaps in services and needed services. So can you isolate all your patients with X diagnoses and be sure that they're receiving the appropriate services for those diagnoses? Can you identify those patients that have not yet received certain preventative services so that you can make sure you're communicating that need for those services with those beneficiaries? So you are using your data to slice and dice your patient population so that you can understand the patient needs and respond to them specifically. The other practice activity requirement that is new with APCM is your performance of assessment through performance measures. Specifically focusing on primary care quality, total cost of care, and as well as meaningful use. And we'll dive a little deeper on that matter right next. This is the table taken directly from the Federal Register, good old Table 25, which goes through the service elements and the practice level capabilities, providing you a more robust explanation. So if you are looking to bill APCM, I encourage you to review this carefully. Use it as a checklist to ensure that you are in a position to bill for these codes. With regard to those performance measures I mentioned previously, there are 4 options for a practice to meet this requirement. If you are a part of a TIN that's participating in the Medicare Shared Savings Program, we're going to assume that you are doing the measurement that's required. That's also going to satisfy your requirement with regard to patient population level management requirement because of the data that you receive back from CMS as an MSSP participant. If you're part of ACO REACH, making care primary or primary care first, that is also going to meet the requirements for performance measurement. If you achieve the status of a qualifying APM participant under the quality payment program, you check the box there. And what most of us are going to end up in is the box that if you are a MIPS eligible clinician and don't meet any of the three above, you're going to register and report that value in primary care MVP. If you, for some reason, do not qualify as a MIPS eligible clinician, either you're newly enrolled or you have such a low volume of traditional Medicare billings, Part B billings, then this particular requirement is waived for you. Medical record documentation is sort of the scariest part of this new rule because we're expected, if it didn't document, it didn't happen. But how do you document some of these services? What CMS is looking for is that electronic patient-centered comprehensive care plan that Lori previously discussed for every patient for whom you're going to bill APCM. The elements that, to the extent you are engaging in outreach to the patient, the clinical staff are interacting with the patient, spending time with the patient, that would be captured in the medical record as all. And that leads us to the question, and I think, Lori, this is the most common question we've got about APCM. Does it become the floor? If you have a CCM program that you've created, you are well aware that there are months where you just don't cross the 20-minute threshold, or a PCM program where you just don't cross the threshold. Are we now effectively creating a floor that allows that practice to bill for APCM in those months where they don't cross the 20-minute thresholds? They're still tracking time like they would traditionally under CCM. But now, can you then have this as a floor? We've cited here the language from the rule, which leads us to conclude that, yes, it can be a floor so long as you've met those additional practice requirements that are called out specifically for APCM. Billing for APCM, remember that submitting the claim means that you are attesting to CMS compliance with all required practice capabilities. So meaning if you bill for this and you don't meet a practice capability, you've submitted a false claim, and we all know where that goes with a false claim. You're going to bill this code once per calendar month. There is no add-on code for APCM. It has to be billed by that practitioner who has assumed responsibility for the beneficiary's primary care. A billing practitioner and another practitioner in the same practice at the same specialty cannot bill certain services in a month in which APCM is billed. These are not any surprise, right? It's CCM, PCM, TCM, as well as those other services that are related: interprofessional consultation, remote evaluation of patient images, and virtual check-ins and e-visits. You still can bill separately for the remote patient monitoring codes, as well as behavioral health integration and interprofessional consultation. Again, as we said again over and over, Medicare cost sharing still applies to these services. Why CMS can't partner up with the U.S. Preventative Task Force and decide that these are preventative care services and this way? Okay, sorry, I've been on that soapbox a few times, haven't I? Here's show me the money, as they say, but here's the current reimbursement across all the codes that we have discussed. Remember, if these look lower than 2024, it's because they are. These reflect that 2.83% reduction in the conversion factor for 2025. Fingers and toes still crossed that Congress will come around and provide an appropriate raise on the Medicare physician fee schedule. Also, just call your attention to the OPS payment for certain of the care management codes. If furnished in a hospital outpatient department setting, there is the opportunity to bill for a corresponding APC, and the reimbursement, the national payment rate, is reflected here. Of course, all the rules about hospital outpatient departments that are off campus and grandfathered and all of that apply too. So these are just the baselines for you to look at. Last but not least, on the subject of care management services, we would refer you to our just updated white paper on providing and billing Medicare for care management services. Lori and I think this is year 9. I think we may have lied when we said it was year 10. Yeah, but it's year 9 for this puppy. And we update it every year with the current rates plus any communications we've seen from CMS. So we think it's everything in one. It's kind of this in the kitchen sink when it comes to these billing rules. And this year, thanks to Lori's very good insight, we highlighted in yellow the specific content that's new for 2025. And we did this year go into depth on APCM. So you'll see that addressed in the white paper as well. And last, but just to note that in your resources pane, you'll see a link or at least a PDF copy, I'm not sure which, to the white paper, the updated version. Okay, enough on that. Let's switch gears with our remaining 15 minutes and talk about remote patient monitoring. Very briefly, remember we have remote physiologic monitoring. This is the collection of physiologic data from an individual related to either a chronic or an acute illness that is used then in developing and managing that patient's condition. So you're actually using the data. The two words Lori and I come back again and again to with remote monitoring is medical necessity. There has to be a reason to monitor the condition, and the data that is generated from the monitoring must in fact be used in addressing the patient's condition by the treating practitioner. We go back to that again and again and again when questions arise about the appropriateness of certain monitoring. Note here the specific device requirement CMS has proposed. It must be a medical device under the Food, Drug, and Cosmetic Act, but not necessarily one that has been cleared. If the clearance requirements apply, then it certainly needs to be cleared, but it doesn't necessarily have to be an FDA cleared device. The device for physiologic monitoring has to be capable of uploading patient physiological data automatically. It's not the patient self-recording and then transmitting the data. It's the device that's taking the blood pressure, not the patient taking the blood pressure and then entering the result and transmitting it. And then finally, that device has to be capable of generating or transmitting daily recordings or an alert if the beneficiary's values fall outside some predetermined range. Additionally, the rules regarding ordering and consent for RPM, the service must be ordered and billed by an eligible practitioner. That includes physicians and non-physician practitioners who are eligible to bill for E&M services, as well as RHCs and FQHCs, more on that later. You must have the established patient relationship. That's distinct from the CCM initiating visit requirement, but you have to be in a position of, it's the definition that we use to determine whether you bill a new patient for an E&M service, either as new patient or established patient. So they've received professional services within the last 3 years from the practitioner or a billing practitioner in the same practice in the same specialty or subspecialty. And keep in mind this idea of referring practitioner versus billing practitioner and the potential issues there of who has the established relationship with the beneficiary. And similar to all the CCM, PCM codes, you also have to obtain consent prior to or at the initiation of the services. Same rules that Lori discussed previously.
And Martie, we get questions. I was going to point out on that one is, can you do a blanket consent at the beginning and just have, you're consenting to all care management services that we may provide for you, and we recommend against that. It needs to be specific for each of the programs. And then in the latter programs, they've been very specific that it has to talk about this one separate from this one, separate from that one.
Lori, I hate to do this. I'm going to go back to APCM real quick, and I should have pointed that out. This idea of APCM being the floor, only if you have consent
Exactly.
for the patient for APCM in advance, right? So you'd need a CCM and a separate APCM consent is what we recommend for folks. Sorry about that. Didn't mean to digress.
Nope, it's important. I think that we hit on that. So just to run through the codes again for everyone's benefit, 99453 is the service initiation code. And so that is for where the practice is helping the patient by setting up the device and educating the patient on the use of the device. There are no assigned work RVUs, so they are not anticipating these services to be provided by the physician or a non-physician practitioner. They're anticipating it to be staff because there is only that practice expense included. It is reported only once for each episode of care, even if multiple devices are provided to the beneficiary. And so that episode of care is when the physiologic service, the monitoring service is begun, and then when it ends with attainment of the treatment goals. And it can only one provider can be reimbursed for this for the same patient during the same period of time. So if you have a patient and they have a urological issue and the urologist wants to do an RPM monitoring, and the cardiologist wants to, Medicare will only pay for one, even though those two are very distinct and separate. And they haven't told us how they adjudicate that. We assume the first one in gets the reimbursement. Very important is that the device must collect and transmit at least 16 days of data in a 30-day period before this code can be billed. So you see the patient on day 5, you have to have 16 days worth of transmission. So the earliest you could bill this code would be, say, day 21 within the month. And it's counted on a 30-day period from the date on which the data is first collected. So you'll see we have some calendar month and some 30-day month, or 30 days as we look through these. So keep that in mind as we move forward. 99454 is for the data transmission. And so that's for the provision and programming of the device to get that daily recording or those alerts that Martie referenced. And again, the device has to collect the data and transmit the data, no patient intervention in that process. It, again, practice expense only. It's not assigned any work RVUs. Billed once per 30-day period, even if those multiple devices are used, and must also meet that 16-day requirement. So if only 14 days are gotten within a particular month, then and 2 more days are added on, and it bleeds over. That 30-day can bleed over across 2 months to get that, but you have to have that 16 days. There's been a lot of push in rulemaking to try to get that 16-day number lower. If that's something important, the next time Medicare asks for comments, that would be something to submit on individually. There is 99091 for data analysis and interpretation. And so there is, for the analysis and the interpretation. It's a minimum of 30 minutes of time in a 30-day period. There are no add-on codes, but of note, it must be performed by the physician or NPP or clinical staff incident to, provided those requirements are met. The key here is the direct supervision. And so I don't know, Martie, I don't see this one actually used a terrible amount, just because the other codes tend to lend itself more, I think, to most of the programs, and that direct supervision is the key challenge. I think the key limiting factor.
Yep. Shame on me, Lori, because this slide talks about the direct supervision requirement. It has been extended by CMS. The virtual direct supervision has been extended through the end of 2025.
Right. So we can do it virtually, right?
Yeah.
But still has to be available from a direct versus general supervision as the other codes that we were talking about. And again, appears to include that collection and transmissions of that 16 days of data as a precondition. Not as clear there, but that's how we're interpreting it. So then we pivot. Medicare this past year gave very clear guidance that the treatment management codes 99457 and the add-on code 99458 are not limited by that 16 days of data rule. It is for 20 minutes of care management. Yeah, that was a big win. Our clarification that 20 minutes of care management, again, under general supervision. And it must involve at least one live communication with the patient during that 20-minute period. So it doesn't mean that all 20 minutes have to be live interactive, but at some point you have to have connected with the patient. That connection needs to be documented as to who, when, the nature of the communication, and that communication must occur using a real-time synchronous two-way audio interaction. So meaning it can start off, for example, with a phone call, but you have to have the ability to turn on a video and interact via video or other data transmission with the patient during that interaction. Again, only one provider can be reimbursed for 99457 for the same patient during the same period of time. And you can bill 457 and other care management codes, provided you've got distinct documentation separating the type of care management that you're providing. You're not double counting that time, that it's very clear. So one way to think about the differentiation between chronic care management and RPM can be a tool used in chronic care management. If you're not doing all of the activities related to chronic care management, it may just narrow down to the remote physiologic monitoring. And then you can use up to 3 units of 99458, essentially under a medically unlikely edit is where we see we're seeing payers limited up to the 3. And then 99457 and 99091, it's interesting, that's where Medicare and CPT have a little bit of a conflict. The CPT code book says 99091 and 99457 cannot be billed for the same time period for the same beneficiary. However, CMS explicitly walked through a scenario where they felt there may be some instances where there's very complex data. It takes additional time for analysis and interpretation by the practitioner, and that they feel like 99091 and 457 can be billed together in that 30-day period. But again, you can't double count the time between those 2 codes. So you see here the RP. Oh, go ahead.
No, go ahead, Lori. I was just going to get some outreach.
Oh, this one's yours. Yep. Go ahead.
No, well, these are the current 2025 reimbursement rates, national payment rates for the RHPM codes. If you have been tracking this the way we do, you have seen what over the last 5 years, Lori, every single year this goes down. And it's not just going down at the conversion factor reduction, it's going down in the RVUs. So it's like not exactly like CMS is trying to encourage the service. We are in the cycle of the AMA CPT committee review that they are again revaluing these codes by physician survey. So hopefully we will see them going up, but it is enormously frustrating. But we've seen these reductions in the reimbursement for these codes. Again, also note the APCs that are available for 53 and 54, not the other codes, but again, cautioning the off-campus rules, the grandfathered rules and the like kick in as well there.
And Martie, 1 year in particular, when we saw a pretty deep decrease in these codes, we saw an increase in CCM. So again, we thought we inferred that they were wanting to shift the adoption of the CCM codes. So switching quickly to therapeutic monitoring, I want to keep us on time. Again, requires an FDA device, has to have the 16 days of data. RTM is different. Therapeutic monitoring is different because it allows the patient to gather and report the data versus the automatic transmission. So the patient can record pain scale, for example, input it in the device transmits it to the practice for that information. It is limited to 3 conditions: respiratory, musculoskeletal, and cognitive behavioral therapy. The established patient requirement does not apply to remote therapeutic monitoring. Because they're not E&M codes, they can be billed by any professional who can bill under the Medicare physician fee schedule. So we do see, for example, physical therapists being able to bill these codes, and providers cannot bill RPM, physiologic and therapeutic codes for the same patient during the same period of time. So it gets to be a mouthful, and you have to really distinguish when you're saying physiologic versus therapeutic sometimes. Again, you see the diagnosis here, the reimbursement here for these services, both on the Medicare physician fee schedule and the OPS fee schedule. Similar issues related to compliance, care plan, improper supervision. I think just focusing on that autopilot and roster billing, back to medical necessity and clinically appropriate. The services don't last forever. It needs to still be giving information that's important for the physician to continue, or the provider to continue to provide care for the patient. Some of the services, I think, if it's weight loss before surgery or things like that, it seems like it could just continue to expand years, and there needs to be that medical necessity test at all times. Quick plug, we have the remote patient monitoring white paper is also up. You have the link available in your resources. I'll push that to you guys so you can see it here. And then Martie, let's bring it in with the last couple of items on RHCs and FQHCs.
Okay. So for a number of years, RHCs, FQHCs billed for the services we just discussed under G0511. So you would, yes, the RHC or the FQHC had to meet the requirements to bill for a particular service, but rather than billing the CPT code, they would bill G0511. And the reimbursement was flat across the board, about $80 last year. The RHC did not get its AIR, the FQHC did not get its PPS rate. They got that flat $80. And as you saw, when we looked at the reimbursement rates, that would be generally higher than the reimbursement on the fee schedule. But effective January 1st, RHCs and FQHCs can now bill the appropriate CPT code. They'll be reimbursed at the national non-facility payment rate, again, not the AIR or the PPS. They can continue billing G0511 through June 30, of this year. But note that CMS slashed the reimbursement for GO 511, so it's closer to $57 as opposed to the $80. And effective July 1, no more claims for GO 511 are going to be paid. Instead, our RHCs and FQHCs will need to use the specific code, meet all those requirements that we just discussed. There's no variation in those services. Last but not least, let's talk very briefly about what other payers are doing. Medicare Advantage. Go back to 2016 when these codes first came out. MA plans pushed back, saying we actually provide these services directly. We shouldn't have to pay a provider. It's a matter of covering the service, not necessarily reimbursing providers for the service. CMS agreed and said if the MA plan believes it's already providing the service directly for their patients through their care management activities, they do not have to pay a provider for those services. And so that has been the rule going forward. And it's sort of all over the map on how that rule has been applied. Some plans have even asserted it with respect to RPM, which I think is pretty questionable because I doubt they're doing the actual monitoring, but that's the position we have. So there is some variation from MA plan to MA plan on whether they pay. When you get down to state Medicaid programs and commercial payers, it's kind of all over the map. In fact, you'll get United has different policies that they apply depending on the particular product that's involved. So it's a matter of finding on those online tools, determining whether payment is made or not. So there we go, a whirlwind through the RPM, CCM rule. You guys have been asking a ton of questions. Lori and I will sort through those, get back with you versus email. And last but not least, future HCRR webinars. February 26th, we're going to take a deep dive into the proposed HIPAA security rule with our good buddy, Barry Mathis, head of our IT group. And then on March 5, I'm going to be joined again by Kathy Reep, and we're going to talk about site-neutral payment reform, which appears to be a very hot topic in the world of budget reconciliation. So stay tuned for that. Thank you so much for joining us today. Look forward to seeing you again soon.
Thank you.
Thanks to our presenters, Martie and Lori. Later today, you'll receive an email with their contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any additional questions you may have. On behalf of PYA, thank you for joining us and have a great rest of your day.